I'm Dr. Sara Cichowski, Associate Professor at Oregon Health and Sciences University. One of the other roles I share is I'm a member of the Publications Committee, and I recently served as a liaison for a document published by that group that came out of the leadership of Dr. Krista Reagan.
Hi, Sarah. Good to see you again. My name is Krista Reagan. I am a urogynecologist in private practice or in a hospital-based group practice in Tacoma, Washington, and I had the pleasure and fortune of leading a wonderful group of AUGS members in writing a paper.
So Krista, I want to start with kind of a general question, but why do you think we needed these recommendations on opioid prescribing postoperatively for urogynecologic surgery?
Yeah, great question. So we know from studies that have come out in the last 5 to 10 years that we overprescribe in gynecology. And while the risk of abuse in gynecology after gynecologic surgery is low, it's not zero. We need to be good stewards of our resources, and that's especially critical when we're dealing with a potentially dangerous resource such as opioids. So we need to use caution not only for our patients, but also for the community that our patients live in. We can achieve that by providing our patients with what they need, no more, no less, so that excess pills are not available in the house for kids, for grandkids, or for guests, or for patients to dispose of in a suboptimal manner.
And as you thought about that, as you worked on this guideline, who did you feel the audience was, or the guidance that you were giving directed towards?
Yeah, that's another great question. So the paper was written for female pelvic medicine and reconstructive surgeons. So there are lots of guidelines out there for surgery in general, even for gynecologic surgery, minimally invasive surgery, but we really wanted to hone in on FPMRS and figure out how we could best educate our providers based on the data that's out there. The paper, while it's written for FPMRS, specifically for FPMRS surgeons, the paper is, the data that's available is predominantly on opioid naive patients. And so this paper cannot be necessarily generalized to other patients who may have other predisposing risk factors for needing excess opioids. And those risk factors are detailed in the paper.
As you think about sort of the document as a whole, what would you hope would be the main takeaway that people would have as they read this guidance document on opioid prescribing postoperatively?
Yeah, a couple key takeaway points. Number one is don't overprescribe. We know that we overprescribe frequently. We've done that a lot in the past. And with most systems nationally moving to electronic prescribing, we don't have to worry about our patients not having access to prescriptions, extra prescriptions, if they need them. So we don't need to worry about not being able to control our patients' pain. So from the get-go, we need to not overprescribe. The second thing is to educate providers and educate patients on safe opioid use and also proper disposal. The third thing is multimodal medications work. This has been shown many, many times. Enhanced recovery multimodal protocols are not new. They've been around for over 20 years, starting in colorectal surgery, but now we have copious data in gynecologic surgery that multimodal medications work, so we need to use them. And lastly, some patients use zero opioids. So it's important, it is such a part of our practice. Once we had these very helpful medications to control patient postoperative pain, we want to use them, and that's a good thing, but we need to use them judiciously. And it's also important to understand that there are some patients who will use zero, and as is discussed in the paper, a lot of times that's our older patients. A lot of times one other indicator is patients who use zero opioids while they're in the hospital. Those are patients who may be able to go home with zero opioids. So we don't necessarily, even though it's part of our practice, sometimes it's hard to break those habits. And we don't want patients to be in pain. So we want to be able to provide that to them. But there are some patients who don't need any. And I think, thankfully, the opioid epidemic is more and more prevalent, and patients are aware of it, providers are aware of it. And so even patients are coming to me saying, I don't want opioids after surgery. And again, because we have electronic medical prescribing, if they need it, we can easily get it to them. So remembering to not necessarily give it to everyone, those patients who don't want it or don't need it. And one of the indicators can be if they don't use any in the hospital.
Great. Seems like you've spoken a lot about our need to educate ourselves, educate our patients, educate ourselves about multimodal therapy, and about the potential even kind of novel idea that we don't need to send everyone home with opioids. Switching from education to research, where do you think sort of the areas for research are needed within this field?
Yeah, that's an exciting question. I think there's a couple different areas for research. One, I think we need to do more research on specific procedures, while our paper focused on all FPMRS procedures that were available for study in the literature. I think it would be really helpful if we honed in on certain procedures, and that is already occurring. The good thing about this literature is, even as we were writing the paper, we had to do a couple extra literature searches because the data is evolving so quickly, and this is one area where it is evolving. There are already studies being done, including by one of our authors in the paper out of Penn State. They're working on looking at opioid use after isolated mid-urethral sling. So I think we need to kind of isolate which procedures are causing the most pain and how to best hone our treatment accordingly. So I think looking at specific papers like is being done at Penn State will be helpful. The other thing is that because our paper focused mostly on opioid naive patients, because that's where most of the data is, we need to be evaluating those other high-risk populations. One, figuring out exactly what those high-risk populations are. We know some of the data on that. We know certain risk factors such as chronic pain, chronic opioid use, endometriosis, chronic pelvic pain, but also psychologic factors such as catastrophization, anxiety, and depression. We know that those things might also contribute. So we need to identify those risk factors and also study those populations, since most of the studies are not done in high-risk populations. And lastly, I think we need to continue to explore other pain management techniques. This can include physical therapy, pharmaceutical management, such as liposomal bupivacaine or other treatment options, complementary and alternative medicine, such as acupuncture, massage, maybe even marijuana. Iced tea paper was a great, gave us a lot of great information on a simple thing like applying ice to the area and how that can affect pain. Therapeutic massage, music, cognitive behavioral therapy, all of those things are areas that we could continue to explore to make surgery safer for our patients.
I really appreciate all your expertise and knowledge on this subject, Krista, and I'm hoping maybe we could end with more of a personal note, which is you as a urogynecologist in your practice, how are you counseling patients about opioids postoperatively?
Yeah, I think it's important to start the conversation before surgery. I think patients expect to have pain medicine after surgery, and that's normal. In general, we do provide that. But I think it's important to start the conversation about what patients are expecting. There are some patients who have the expectation of having zero pain after surgery, and unfortunately, we're just not there yet. So getting into that conversation about there will be some pain, but we want your pain to be well managed. We also talk about how important pain control is after surgery. It is really important to have their pain controlled so that they can ambulate, so that their bowels can function, they don't get DVTs, and also the quality of their recovery is better. We know that poor pain control can have negative consequences as well. So starting the conversation before, and then talking to them about the use of multi-metal medications, because to some patients that's new, and how I do want you to use Tylenol and ibuprofen around the clock, and then for the first few days, and then you can switch to PRN use as your pain's getting better, and then you'll have the opioid available to you as needed, and also discussing minimal use. Use it when you need it to get your pain to that level where you can comfortably walk, and not using it when you don't need it. We also talk about alternatives like icing, walking, stretching, comfort measures that they can do that are very personalized to themselves. And then also letting them know that we're here if they need us. So if something's not working, to give us the call so that we can kind of work through things and see what else might be contributing to their pain, such as constipation if they haven't done their bowel regimen.
Dr. Reagan, thank you so much for your expertise. And on behalf of the Publications Committee, thank you for all you did with this group and the group as a whole for an excellent publication and research and thoughtfulness into this guidance.
Yeah, it really was a team effort. We had a wonderful team to work with, and everyone had a lot of experience in opioid work, and so it was just a really strong team, and I was proud to be a part of it. And Sarah, thank you for your contributions too, and for guiding us along this path.